All right, so today we'll talk about multiple nodules, the approach to that. So what's the finding on this chest radiograph? You would call those consolidations, given the topic of the lecture?
No, but like, if I saw it.
If you saw it, you'd saw it consolidations?
I'd say they're massive.
All right. What's the shape?
Round.
The edge is sharp, clearly defined from the surrounding lung?
Circumscribed.
Well circumscribed, so the term we would use for this is
Mass.
nodule, right. Mass is when? When do we use the term mass?
3 centimeters.
Right, so if it's greater than 3 centimeters, you call it a mass, so we have nodules, masses. All right, so bilateral lung nodules here, what's the differential diagnosis? What could this be? Yeah, your first thought is going to be metastatic disease, right? But is there anything benign that can give you bilateral lung nodules? Well, what inflammatory, what infections? So septic emboli, although you'd like to see them more in the periphery, I guess, and with some cavitation, but what infections are notorious for giving you nodules? Certainly TB, and what other kind of infections? Fungal infections, right. So fungal infections can also give you multiple lung nodules. There are other things that are also in the differential, some, rarer things like vasculitis, Wegener's, etc., but your first thought is going to be metastatic disease. So here's the CT on this patient, right? So what are the findings? On the left, we have
multiple rounded nodules, maybe mass, that bottom one.
Right, so we have well-circumscribed nodules. On the right, the finding is?
Same.
Same? You see lung nodules on the right? Yeah. So there's.
Oh, the right.
So what do we have here? We have a large mass. We have masses in the, where are the masses? Retroperitoneum, right. Might be lymphadenopathy, might be mass, right? So what is your differential putting these two images together? What could this be? So lymphoma is a thought, right? Lymphoma certainly can give you retroperitoneal lymphadenopathy, and it can give you lesions within the lung. So that's a consideration. What else? What's the most common primary retroperitoneal tumor? So it could be metastatic disease from renal cell cancer, right? If that's going to be lymphadenopathy. But what if it's a primary retroperitoneal tumor? What tumor would that be? Sarcoma. Sarcoma. In children, maybe. But sarcoma would be a thought as a primary retroperitoneal tumor, like especially, MFH, but sarcomas. Anything else you might consider?
Adrenal.
Adrenal metastases?
Not common.
What if I tell you it's a young male? What? Germ cell tumor, metastatic seminoma. So another term for these kind of well-defined round lesions might be cannonball lesions. Yeah. So this is a patient who had seminoma, testicular tumor. Okay, somebody's not muted out there. All right. So in this case, it's seminoma. That can give you retroperitoneal lymphadenopathy. That can give you cannonball lesions within the lungs. Another patient with bilateral lung lesions, what's different about the appearance of this as opposed to the prior?
More speculative.
Well, more irregular borders, right? Tree and bud? I don't know if I would say tree and bud, but what did you say? Ground glass? Yeah, maybe there's some ground glass in the periphery. So you suggested infection or inflammatory. So what kind of things would you think about then? Why? What particular feature makes you think aspergillosis?
Halo sign?
What?
Halo sign?
Halo sign. You said there was ground glass around the lesion, which is a halo sign. So that can be so. And what form of aspergillosis would that be? Invasive. What would you ask about the patient?
Immunocompromised?
Yes. What particular problem? Neutropenia, yeah. So you would ask if the patient's immunocompromised, is the patient neutropenic? So certainly invasive aspergillosis, right? You can have other lesions also that might give you ground glass halos, like what?
Pneumatoceles. But it wouldn't look like that.
Wait, what did you say?
I said pneumatoceles gives you ground glass.
Well, we did discuss, we talked about a certain kind of lung cancer, right? That can be associated with, what is that?
The ground glass, like,
Mucinous tumors or adenocarcinomas can also be associated with ground glass in the periphery, so maybe you have something like that. Ground glass in the periphery can also indicate hemorrhage, right? So what are metastatic tumors associated with hemorrhage that can be associated with ground glass?
Renal cell.
Renal cell, so you think of vascular tumors, what other tumors?
Melanoma.
Okay, what else? Melanoma is always a good answer, and you have a strange appearance, and what tumor can do this? Melanoma is always... Choriocarcinoma in a female, right. So choriocarcinoma is also notorious for being associated with hemorrhage around the metastases, right? But any hemorrhagic tumor that's metastatic can also do that. In this case, that was invasive aspergillosis. What's peculiar about this case? Your pneumothorax and what? Just one?
The right name.
Yeah, so there's a big mass here, and then you have these other nodules. So assuming Sultan did not do a biopsy on this patient, how do you put these two findings together? When
masses could have been at the pleura, and it could cause pneumothorax.
so there are certain kinds of metastatic tumors that can be associated with pneumothorax. You have a thought? What? Yeah, osteosarcoma, any sarcoma, but osteosarcoma particularly. So osteosarcoma metastases can be associated with pneumothorax. Sarcoma metastases also can be associated with pneumothorax. And so there's a pneumothorax, there's a tumor. There's another peculiar thing about sarcoma metastases is that they tend to be very well rounded, very well circumscribed. So sarcoma metastases tend to look like marbles. They're very smooth borders, very rounded. Okay, the finding here is bilateral nodules. What a surprise. Another case with bilateral nodules, okay? Show you some more images on this case and you see what?
Pleural-based nodularity.
Pleural-based nodularity. Is he correct? Are these pleural nodules?
Yeah.
Yeah, so they're actually not in the lung, right? Where are they? They're on the skin. Right? So these are nodules along the skin surface. So here, what do we think about? Neurofibromatosis, right. So skin lesions can simulate lung nodules on a chest radiograph. That can fool you when you're dealing with pseudonodules. So this is a patient with neurofibromatosis. So what we have here are skin lesions. This patient also demonstrates an unusual finding in the lungs that can also be associated with neurofibromatosis. What is that? Cystic lungs, yeah, these cystic changes within the lungs, so it kind of resembles emphysema, but these cysts in the lungs can also be associated with neurofibromatosis. That's unusual. So multiple pulmonary nodules, especially if they're non-cavitary, most common cause is metastatic disease, of course. We can have carcinoma mets, sarcoma mets, as we've discussed, can be associated with pneumothorax, but other things can also give you nodules like tuberculosis, fungal infections, so that sometimes can also give you bilateral lung nodules. Then there are other more unusual unusual diseases that might also give you lung nodules or look like lung nodules, like pseudonodules or skin lesions. So here we have there's a large cavitary lesion. Do you think this is benign or malignant?
Could be. I could go both ways. But I think malignant.
Why?
Because there's just one.
Just one? Any other finding? What's that?
Air fluid level.
Well, in your fluid level, you can see in any cavitary.
It's thick.
Thick wall, right.
Yeah.
So there's marked thickening of the wall here. So the thicker the wall, the more you're going to be concerned about malignancy. So there's marked thickening of the wall here, right? So what tumor do we think about?
Squamous.
Yeah, this was primary squamous cell cancer of the lung in this patient. Okay. All right, so the finding in this case is?
Multiple cavitary lung.
So we have bilateral lung nodules, some of which are
Cavitary.
cavitary, the differential diagnosis here. So you're going to think about septic emboli. You like septic emboli for this, yes or no?
It's randomly distributed.
Yeah, the distribution seems a little bit random. Does that bother you for septic emboli?
No, that's typical.
Typical?
It should be like peripheral. You're most likely to be peripheral.
Yeah, so you're most likely peripheral, but it can happen anywhere. So certainly it's something to think about. So septic emboli is in your differential. Anything else in your differential?
Vasculitis.
Vasculitis like? Yeah, so Wagner's or GPA now. Anything else?
That's
Well, let's look at some more images on this patient. So we have bilateral lung nodules, some of which are cavitary, some images through the abdomen and pelvis. What are the findings there on those images?
Hydronephrosis.
Yeah, so there's bilateral hydronephrosis, and then in the pelvis, yeah, there's some cystic mass there, cystic masses. How do we put those findings together? Choriocarcinoma, is that associated with cavitary lung lesions? By the way, yeah. Anything else? Squamous cell metastases. So squamous cell metastases are associated with cavitary lung lesions when they metastasize to the lungs. So what tumor would this be then?
cervical cancer.
Cancer of the cervix. Yeah, advanced cancer of the cervix. That's squamous cells. So that's why you have advanced cancer, and that is associated with hydronephrosis. That can result in hydronephrosis, pelvic masses, in this case, the metastatic disease to the lungs, which are cavitary. So squamous cell metastases can also give you cavitary lesions in the lungs. So the finding on this chest radiograph is
Nodules.
that it?
Left pleural base 1, there's a line.
Anything funny looking about these nodules? Some are cavitary, yes, some are cavitary. You're only allowed one guess. If you're only allowed one diagnosis on this case, what would it be? Why?
As a source.
Patient has a central line and the nodules are located where? Periphery. So these are peripheral nodules with cavitation in a patient with a central line. So given those findings, the first thing on your list is going to be septic emboli. Okay, so this is a patient with septic emboli. So our differential for cavitary lesions, septic emboli, cavitary metastases, especially squamous cell cancer, infections, TB, fungal infections, necrotizing pneumonias, and then some other rare things that can also give you cavitary lesions. So squamous cell metastases, they can give you cavitary lesions within the lungs. We've talked about wall thickness before. The thicker the wall in a cavitary lesion, the more you're going to be concerned about malignancy. So especially if you have thick-walled lesions, you're going to think about malignancy within the lung. As an example of cavitary metastases from head and neck cancer in this patient, thick-walled cavitary lesion there. Looks like there might be some high-level lymphadenopathy, but cavitary metastases. We can see that with squamous cell cancer. Can be from the lung, from the airway, from the head and neck, even esophagus. Any of those can give you squamous cell metastases. We saw the case of primary squamous cell cancer here with a thick wall, your fluid level. This was a primary squamous cell cancer. Septic emboli, predisposing factors, IBDA, especially tricuspid valve endocarditis, central lines, prostatic devices, immunocompromised patients. We look for peripheral nodules or opacities that cavitate, predominantly lung bases. Nowadays, the feeding vessel sign really not helpful. With thin section CT, you can see a feeding vessel going to any lesion because of the thin sections. But we saw a classic case of septic emboli with peripheral lesions, some of which are cavitary. So multiple cavitary nodules. Here we have nice thin walls. So we always think of septic emboli when we see multiple cavitary nodules. The thing to remember, though, is that especially on portable chest radiographs, these can be very subtle. Anybody see one here?
Yeah, there's one there on the left.
This guy over here is really subtle, right? So these can be very subtle, especially on portable chest radiographs. So that's why if I have a low threshold for doing CT on any patient where they suspect infection. And you're always surprised by how many more lesions you can see on the CT than you can see on the chest radiograph. So again, we have lesions with cavitation located in the periphery. We're always going to put septic emboli there at the top of the list when we see something like that. Okay. Pulmonary infarcts, usually these don't cavitate, but the large ones, even if they don't get infected, you can have aseptic cavitation in large infarcts, big PEs here with a large peripheral infarct. So sometimes cavitation can occur in pulmonary infarcts, although they'll tend to be large. Then we've talked about cavitary metastases, head and neck, esophagus, cervix, lung cancer. These are all tumors that can give you cavitary metastases because they're squamous cell. However, sometimes even adenocarcinoma might give you cavitary metastases. But squamous cell is the tumor we like to start with if we're talking about cavitary mets. We have a 43-year-old woman with cough and fever. There's our initial chest radiograph. Here's our chest radiograph 10 days later. First, we describe the findings. What are the findings here on the initial chest radiograph?
Right upper lobe opacity.
What do you think that is, given the history? There's cough and fever. What are you going to call it?
Consolidation.
What do you, is the
Pneumonia.
consolidation here? So pneumonia, right? So you have a big lobar pneumonia there in the right upper lobe. 10 days later, is it better or worse? Well, what do we see 10 days later?
Spread to the left as well.
So we have multiple consolidations now, not just there, but it seems to affect the lungs now bilaterally. That consolidation started where?
Right upper lobe.
Right upper lobe. Do you have anything to say about that consolidation 10 days later?
A lot bigger.
It is bigger, yes. Is there anything else you notice about it?
And also, yeah, what he said.
What?
There's airhead now.
What does that mean?
Necrotizing.
Okay, so there's cavitation. So we think necrotizing pneumonia here, right? So you have a rapidly progressing necrotizing pneumonia. The consolidation you said is bigger. Any specific diagnosis you might want to suggest here? What happened to the size of the right upper lobe?
Increase.
What?
It increased.
It got bigger.
Yeah.
So
Maybe empyema,
is that empyema?
No.
Why not?
because there's no fluid level.
Empyema is infection where?
Pleural
Oh, yeah.
space.
Pleural space. This infection is where?
Parenchyma.
In the lung parenchyma. So we're not going to say empyema. We don't see big effusions. If you saw effusions, of course, you would suggest that empyema is a complication. Well, what kind of pneumonia can cause the lobe to get larger and is necrotizing?
Staphylococcus.
Staph can do that. Klebsiella can do that. There's a particular name we attach to those kinds of pneumonias. What is that called? So notice that the lobe itself is increased in volume. There's cavitation there. The pneumonia is spread bilaterally. Anybody know the name we attach to this? Friedlander's pneumonia, when the lobe actually gets bigger in size. And the organism somebody mentioned, the typical organism is,
Staph.
no, Klebsiella. Although staph can do it, the negatives also would be there because you have necrotizing pneumonia. But Klebsiella especially can do this. This was a case of Klebsiella pneumonia causing the lobe to get larger and, of course, rapidly progressive with cavitation. All right, so necrotizing pneumonias. Cavities associated with extensive consolidations. You see that these destroy the lung tissue here. So staph, Klebsiella, Pseudomonas, anaerobes, other gram-negative organisms, all of these can give you necrotizing pneumonia as a result of bacterial infection. Okay? All right, so the lungs look normal? Yes or no? No, what's wrong?
Peripheral opacities.
Yeah, peripheral opacity. One or more than one?
Oh, multiple.
Right, so there's more than one. There, okay. Here, I'll give you a close-up of that opacity. Anything to say about it?
Yeah, it's cavitary.
It's cavitary. Surprise, we have multiple opacities with cavitation. Okay, so our differential diagnosis, reaching back into what we've learned, we would suggest what?
Septic emboli.
Septic emboli,
Metastases.
squamous cell metastases, vasculitis.
Primary squamous cell. Well, it would be more.
Well, there's more than one.
Infection.
Pneumonia is infection. But of course, there's another finding on the x-ray that really helps.
The shoulder joints.
What about the shoulders?
I mean, there's definitely some kind of, I mean, you're going in the rheumatoid direction, so.
But I want you to go in that direction, so you tell me what the finding
I
is.
would say
Finding
they
of the
look like,
humeral
it looks like joint space narrowing,
It's
maybe
finding of the humeral
periarticular,
All right, so what are the findings associated with rheumatoid?
periarticular osteopenia, joint
Narrowing.
space narrowing.
What do you call this big thing?
Oh,
Erosion.
That's an erosion, right? There's joint space narrowing, the location of the humeral heads.
High riding,
High riding, because,
pneumocromial joint space narrowing,
yes, well, what's happened to the distal clavicles?
pencil,
Right, resorption of the distal clavicles, right? Is this unilateral disease or bilateral?
bilateral,
It's bilateral. You have bilateral disease affecting the joints with erosions, right? The changes in the distal clavicles. So it's a classic appearance of rheumatoid, right, within the joints. And so then you might suggest that these cavitary lesions in the lungs represent what?
rheumatoid nodules.
Rheumatoid nodules or necrobiotic nodules. So if you suspect that, what clinical question might you ask the patient? I guess I'm not the patient, but maybe the referring physician beside. We know the patient has rheumatoid, but in most cases, they have longstanding rheumatoid, right? But one other thing that about 90% of these patients also have is what?
Hand pain? Hand pain?
Well, it's from the rheumatoid. We know they have rheumatoid. It's a given. What else would you look for? What else might you ask the clinician? These are necrobiotic nodules in the lungs, right? So what else might you ask the physician?
Are they
Are they on
compromised?
Well, where else do they get necrobiotic nodules? Subcutaneous, right? You would ask their friend, does the patient have subcutaneous nodules, necrobiotic nodules, right? Those patients also, they would have an increased incidence of rheumatoid nodules. Remember, this is rare. Even in patients with rheumatoid arthritis, to develop rheumatoid nodules in the lungs is pretty rare. But the question you want to ask is, do they have skin lesions? Do they have necrobiotic nodules in the skin? So there are changes of rheumatoid in the shoulder. These, of course, are cavitary lesions, and anywhere else this would probably be in real life something else. But here in this conference, these are necrobiotic rheumatoid nodules. A patient with rheumatoid arthritis. All right. So we can then go into this little detour. Let's talk about rheumatoid arthritis, the thoracic manifestations of rheumatoid arthritis. The most common is pleural disease, pleuritis from inflammation, so they'll get pleural effusions. You also see pulmonary fibrosis, so we do see that as a complication of patients with rheumatoid arthritis. Rheumatoid pulmonary nodules, very rare, and everything else on this list is also very rare. Although rheumatoid arthritis, this is worth remembering, is more common in females, thoracic manifestations are more common in males, okay? But the big two, usually pleural disease, interstitial fibrosis, those are the most common things that you would see associated with rheumatoid arthritis. For the pleural disease, pleural effusion, pleural thickening, usually small to moderate effusions, usually unilateral, may recur, can result in pleural thickening in up to 20% of cases. Sometimes they might even be hemorrhagic. Pulmonary fibrosis with rheumatoid arthritis, so in about 5 to 10%. But remember, rheumatoid is a very common disease, so that means that it is something that you do consider whenever we're dealing with a case with pulmonary fibrosis. We usually give a differential, idiopathic pulmonary fibrosis, or underlying connective tissue disease. The most common underlying connective tissue diseases associated with pulmonary fibrosis are rheumatoid arthritis and
Lupus.
not lupus, scleroderma, right. Lupus can give you interstitial fibrosis, but that's not the most common manifestation. Usually lupus lung, areas of hemorrhage and consolidations from lupus. And also lupus is notorious for pleural effusions also, okay? Again, males greater than females, usually occurs after the onset of arthritis, all right? So usually it's known that the patient has rheumatoid arthritis, but there might be cases where, they don't know. Pulmonary fibrosis, so usually looks like UIP, right? Or it is UIP. Why do we call that UIP?
Or peripheral.
Peripheral, what else?
It's a base.
Honeycombing.
Honeycombing, yes. Peripheral reticular opacities with honeycombing and traction bronchiectasis. That's what we look for UIP. They can also have an NSIP pattern. Sometimes, what is the NSIP pattern?
Is that subpleural sparing?
You might see subpleural sparing, yes. What else? Ground glass with? Why is it fibrotic? What do we see that makes it fibrotic?
Bronchiectasis.
What do we call that? Traction bronchiectasis. Do we see honeycombing? No. This is UIP. Don't look at that one.
Oh, I thought you were talking about that.
Right, but NSIP does not give you honeycomb.
Right.
But that's another pattern we can see. Less common patterns, OP stands for organizing pneumonia. What do we see with organizing pneumonia in the lungs? You will see Ground glass and consolidation, mostly consolidations. What is it about them, though, that makes us suggest organizing pneumonia? Peripheral distribution, right, of consolidations for organizing pneumonia. And BO, no jokes, please, but BO stands for bronchiolitis obliterates, right. So that's also a rare manifestation of rheumatoid arthritis. The most common UIP or NSIP in terms of interstitial lung disease of what we might see. The lung nodules, these are necrobiotic pulmonary nodules, identical to these subcutaneous nodules. It's very rare, okay? Again, more common in males. 80% of these patients will have subcutaneous nodules. So if you're entertaining this diagnosis, that's the question you would ask to refer. Does the patient have subcutaneous nodules? Yes, oh, these could be necrobiotic nodules from rheumatoid. Rheumatoid is usually well established and advanced. Well circumscribed, round or lobulated nodules, multiple, you can have cavitation in 50%, might have pleural manifestations. Nodules can get bigger, resolve, or remain stable. So they might grow slowly, these rheumatoid nodules. So we saw our case, the rheumatoid changes within the shoulders, and we saw the case of the cavitary nodules here in rheumatoid arthritis. I will tell you this patient is a co-worker with lung nodules. What do we call this?
Co-worker pneumoconiosis.
Well, no.
No?
Caplan syndrome. So what is Caplan syndrome?
That's rheumatoid arthritis, and then they inhale an organic dust, and they get pneumoconiosis, so it's rheumatoid plus pneumoconiosis.
What are the nodules in the lung? See the nodules? What are these nodules?
Non-cavitary.
Yeah, I know, but what are the nodules? What makes the nodules? This is case of Caplan syndrome. What causes the nodules in the lung? Are those tumors? Is that cancer? What are those nodules in the lungs? Those are necrobiotic rheumatoid nodules. That's the point, which you all missed, right? So what is Caplan syndrome? Caplan syndrome is patients with rheumatoid arthritis who are also co-workers. They can develop co-workers pneumoconiosis, but they also develop nodules in the lungs. The nodules are necrobiotic rheumatoid nodules. Okay, so for some reason, the exposure to the coal or the silica accelerates the development of these necrobiotic nodules within the lungs, right? So those are rheumatoid nodules that can form within the lungs, right? Associated with co-workers pneumoconiosis or silicosis. The findings of the pneumoconiosis usually are not striking, but they can develop these crops of nodules within the lung. Usually or typically, classically, about the same size nodules. Crops of lesions, they can grow rapidly, then stabilize, might have cavitation or calcification. You might have a background pattern of simple co-workers pneumoconiosis, but it's really the history there, the rheumatoid history, and the fact that they're exposed to coal or silica. Pulmonary vasculitis, pulmonary hypertension. So sometimes these patients can develop pulmonary hypertension. There's nothing specific about the appearance. Just looks like all other cases of pulmonary hypertension with big central pulmonary arteries, right? But this is also a rare manifestation of rheumatoid arthritis, this vasculitis that can affect the pulmonary arteries. All right, so if I tell you this patient has renal failure and we have these lung lesions, what are we thinking about here? GPA vasculitis, right. So we have cavitary lesions in a patient with renal disease, we think GPA. And so it's a granulomatous vasculitis, disseminated small vessel vasculitis. Now, there is a form called limited Wegener's, and this is where we might be the ones who make the diagnosis based on the lung findings, because it affects about 10% of patients, and it affects the lungs without renal or other systemic involvement. So this is why we include, if you have cavitary lesions, on your imaging, why you might include vasculitis in your differential, because there are these cases where it might be the only manifestation of the vasculitis. With GPA, the upper respiratory tract may also be involved, so you can also get tracheal involvement with GPA. 95%, so the workup will have elevated ANCA, 85% at C ANCA in those patients, elevated ESR, and upper respiratory symptoms, sinusitis, rhinitis, otitis, more common than the lower respiratory tract symptoms in these patients. Chest X-ray focal opacities, nodular masses, sometimes ill-defined consolidations, and we might get cavitation in these cases. So we included in our differential of cavitary nodules. So cavitaries from ischemic necrosis or infarcts from vasculitis. Sometimes they might also develop pulmonary hemorrhage. It's also in your differential cases of diffuse pulmonary hemorrhage. And the airways can also be involved, so there can be patients who have tracheal wall thickening or bronchial wall thickening associated with GPA. What is this called?
Is this an Aspergilloma with a halo sign?
Well, let's go back to what is the sign on the radiograph itself. What do you call this sign? This is, yeah, so it's air crescent sign, right? When you have this peripheral crescent of air, right? Now, the air crescent sign itself is associated with, as you said,
Aspergilloma.
what? No, not Aspergilloma.
The invasive
Aspergillosis, right. So technically speaking, although some do use it interchangeably, we'll talk about that. But the air crescent sign is associated with invasive aspergillosis, right? So where you get this cavitation, but there's this, it occurs in the periphery and you get that crescent of air. So the air crescent sign, air within a cavity that forms this peripheral lucency or crescent of air between what looks like an intracavitary mass and the cavitary wall, also called the air meniscus sign. Anything that cavitates, although we associate it with aspergillosis, but anything that cavitates can theoretically give you an air crescent sign. So any cause of cavitation might do that, although the air crescent sign itself we do associate it with invasive aspergillosis. Now, what am I showing you here? There's a large bulla here, right? There's this large lucency, which in this case is a large bulla. Anything peculiar about it? What? Well, what do you see? Yeah, there's this dependent nodular opacity within this large air collection, right? So this dependent nodular opacity you suspect represents a fungus ball or aspergilloma. Is there a way to prove it? How could you prove it?
CT.
And what would you do on the CT? You said you could have some fun, yes. So there it is. We've moved the patient in the decubitus position, and you see that it moves around within the cavity, right? So that is a fungus ball within the cavity that moves around, right? So that is an aspergilloma. Okay. Now, what is the difference between the air crescent sign and the Monod sign? You were getting, so some of you were getting at it, but
The crescent is like retraction of the blood tissue, so it forms after the aspergilloma.
yeah, so the air crescent sign is the cavity forms as a result of the infection, right? So the infection itself causes the cavitation in the periphery, and that gives you the air crescent sign. The Monod sign is when the aspergilloma grows within an air collection. And then that peripheral lucency just represents what's left of the air collection after the aspergilloma is growing within it. So it's a difference in terms of how it's formed. With the air crescent sign, the cavitation causes the air. With the Monod sign, there's a pre-existing cavity in which an aspergilloma forms. All right, so that's the technical difference between those two. So the Monod sign means an aspergilloma is growing in a pre-existing cavity, and so the peripheral lucency is not cavitation caused by the aspergilloma, but what is left of the cavity as the aspergilloma grows in the cavity. Okay? So this patient is neutropenic after chemotherapy for lymphoma. We saw this case earlier, right? So this is a case of invasive aspergillosis, so that can be associated with ground glass halos. So any patient who's neutropenic or immunosuppressed, if they develop multiple nodules, then we want to suggest invasive aspergillosis so they can start treating the patient. If I tell you this patient has a history of asthma, what's the finding here on the CT?
Severe bronchitis.
Yeah, so there's bronchiectasis. The location of the bronchiectasis here is central, perihilar kind of central bronchiectasis. So how do we put this together?
Cystic fibrosis.
You said he has asthma. I didn't say he has cystic fibrosis.
Maybe he's lying.
Although it's not, sometimes patients with cystic fibrosis are misdiagnosed as asthma, especially in young patients. So, don't forget about that. But,
Yeah, it's ABPA.
huh?
ABPA.
ABPA, allergic bronchopulmonary aspergillosis. So in ABPA, asthmatics are susceptible to that. The fungus grows in the airways that causes damage to the airways, mucus plugs, bronchiectasis. So an asthmatic who's developed bronchiectasis, especially if you see mucus plugging, you might want to suggest allergic bronchopulmonary aspergillosis. I'm asking for a diagnosis on this chest x-ray. I will tell you it is not TB, it is not sarcoid, and it is not, what is NTB, NTMB stand for? What does that stand for? NTMB.
Non-tuberculosis.
Non-tuberculous mycobacteria. Right. What's the finding on the chest radiograph? What?
I was thinking those were all my guesses. But
Oh, yeah, that's exactly right. That's why I put them up there so we wouldn't waste time.
well, looks like maybe fibrotic or scarring.
Where?
On the lobe.
How do you know it's scarring? I didn't know this is not a tumor.
You can see like hair. Sort of thing.
Well, what tells you it's scarring?
Oh, the loss of volume.
Yeah, there's architectural distortion, right? So the lung is smaller on this side, the hilum is elevated here, right? So there's some volume loss, also some apical pleural thickening, right? So there's scarring here. Also on the right side, you have reticular opacities, kind of fibrobullous changes, some nodular opacities. The distribution of disease is bilateral upper lobe. So you have a disease here that is causing bilateral upper lobe scarring and fibrotic changes. Of course, TB would be your first thought. Sarcoid might be your second thought. Atypical mycobacterial infection might be your third thought. What's left?
Oh, hypersensitivity.
Not a bad idea, although it usually doesn't cause this extensive change, but certainly that you might consider that. Yes, HP. Fungal infection, like which fungal infection can give you upper lobe disease that looks like TB? What fungus does that? Histoplasmosis, right? So that's another thing you might consider.
Pneumoconiosis as well.
Which pneumoconiosis?
Not asbestosis.
Not aspergillosis. Well, that leaves what? There are only two you need to know, right?
Like, it could be like
Silicosis. The only two you need to know, silicosis and asbestosis, right? So if it's lower lung, it's asbestosis. If it's upper lung, it's silicosis. Okay. So you see that 6 years later, right? This is 6 years later, so it does progress, and it progresses slowly, right? Now the cases I showed you before this, if you were paying attention, what were the cases that I showed you before this?
Most infectious.
What cases did I show you? Where's your short-term memory? What cases did I just show you before this case? Oh my God, you. Let's go back. All right. I showed you this, which is ABPA. I showed you this, which is
Aspergillosis.
invasive aspergillosis, ABPA. What do you think this is? So this is also aspergillosis. So this used to be called semi-invasive aspergillosis, right? But now the correct terminology now is chronic necrotizing pulmonary aspergillosis. Okay, so aspergillosis. So in addition to fungus balls, in addition to invasive aspergillosis, you can also have chronic necrotizing pulmonary aspergillosis, which gives you chronic infection in an upper lung distribution, can look like tuberculosis. And we've also talked about allergic bronchopulmonary aspergillosis. So the fungus ball grows in a pre-existing cavity. What causes the pre-existing cavity? Sarcoid, bullous emphysema, TB. It's important to realize that although the fungus here you see floating around in the cavity, it actually lines the whole cavity. And it results in an inflammatory reaction in the wall, and that's why you get some wall thickening and apical pleural thickening. The complication of this is what? What? No, not pneumothorax. No. Hemorrhage. So because of the inflammatory changes in the wall, these patients can develop hemorrhage, and sometimes that can be life-threatening. Right? And then in some cases, it can become invasive also. But that's the fungus ball. And we saw a nice case of the fungus actually moving around in the cavity. So it grows and then, might fill up a large portion of the cavity, as in this case. It's common to have adjacent pleural thickening. And again, because the walls are lined by fungus. The fungus ball is not the only fungus here within the cavity. So the finding here on the CAT scan is
Like a mass,
with,
like showing red mass.
yeah, very nice ground glass halo there. And then 3 days later,
Now there's a rim of air.
what do we call this?
Air crescent.
That's an air crescent sign, right? So it's formed after the nodule is formed, right? So this is a nice example of invasive aspergillosis, right? So it's an example of invasive aspergillosis. Angioinvasive aspergillosis, usually immunosuppressed patients who are neutropenic, the fungus invades the blood vessels, resulting in thrombosis, infarction, and nodules. So the ground glass halo is really bleeding around the infection. That's what gives you the ground glass halo. In these cases of invasive aspergillosis, later on they go on to develop the air crescent. Now the air crescent formation tends to coincide with what in these patients? Improvement in the white count. Yes, so it's thought to be an immunologic reaction to the infection. That as the white count is getting better, that's when you tend to see the air crescents, the cavitation in the periphery of these lesions. Okay? So is a very nice, another nice example of angioinvasive aspergillosis. Starts out as a consolidation. 1 week later, a peripheral crescent forms in there, right? So that is invasive aspergillosis. So they will start out with these consolidations or mass-like lesions or nodules with ground glass halos. And if you have the right scenario, immunosuppressed patients, it's important to suggest a diagnosis here so they can start treating the patient early on. So you don't want to wait until you get the air crescent sign to make the diagnosis. Hopefully you can jump on it when you see these changes earlier on, okay? That's angioinvasive aspergillosis. Now, there is a form of invasive aspergillosis that can affect the airways. It can give you tree and bud nodules, and this tends to affect patients who have AIDS and HIV. So the fungus grows within the small airways, results in bronchopneumonia, tree and bud nodules. So that is airway invasive aspergillosis. And then we touched on chronic necrotizing pulmonary aspergillosis, used to be called semi-invasive aspergillosis. So here, this is chronic infection with aspergillosis. These patients usually have some chronic underlying problem like COPD or diabetes or some of these other issues that results in some mild systemic immunosuppression, underlying lung damage, COPD, pneumoconiosis. So they develop chronic infection with aspergillosis. It goes on for months or years, and it can look like TB, so it can be very slowly progressing. So they can develop cavitations, they can develop fibrotic changes within the lungs, but the time course is dragged on. It can last for months. And so here's another case where you have these cavitary changes, actually just bronchiectasis and some cavitary changes with fibrosis and volume loss in the left upper lobe. Looks like tuberculosis. So it's something to suggest, especially if the cultures keep coming back negative and they're kind of stumped as to what it might be. So they wanted to do fungal cultures. So it could be this chronic aspergillosis infection. And then allergic bronchopulmonary aspergillosis. This will occur in patients with asthma. So they develop mucus plugs and bronchiectasis. Also patients with cystic fibrosis, they're also susceptible to developing allergic bronchopulmonary aspergillosis. Mucoid impaction, that's the finger and glove sign, bronchiectasis, consolidations, atelectasis, upper zone fibrosis. All of this can be seen with ABPA. Here's a branching tubular opacity, so that represents mucoid impaction or the finger and glove sign. And what can be peculiar about this is that sometimes that mucoid impaction can be high in attenuation, even on non-contrast CT because of calcium and metallic ions in the mucus associated with the fungal infection. So that's something we can see with ABPA. And the central perihilar distribution of bronchiectasis in an asthmatic, you suggest ABPA. these different forms of aspergillosis, it's interesting how they're related to the immune status. So invasive, those patients are severely impaired, neutropenic. Airway invasive, AIDS patients, semi-invasive or chronic necrotizing aspergillosis, chronic underlying disease. Non-invasive, the fungus balls, that can occur in patients who do not have immunodeficiency. And then asthmatics you can think of as being hyperimmune, and they develop allergic bronchopulmonary aspergillosis. So that's kind of an interesting way to categorize it also. The finding here, what do we have?
Thick walled cavitary lesion.
I don't know about thick wall, but there is a big cavitary lesion, right? But what's peculiar about it?
Nodularity of the inferior margin with little, like, what I say, it's like linear, curvilinear.
Yeah, that is a very strange appearance, isn't it? That you have this thing at the bottom of this cavity. So, what would do this? Yeah. So in the liver, we have hydatid cysts, right? So this is a parasitic infection, and this represents cyst rupture. So the cyst is made of multiple layers. When it ruptures, the layers collapse from the wall and can actually float around in the dependent portion of the cyst. So that's kind of a pathognomonic appearance of a ruptured echinococcal cyst. So that's echinococcus. So it's caused by this tapeworm. So humans are accidental hosts, so it occurs in sheep-raising regions of the world, okay, and then humans can become accidentally infected. You're familiar with the liver lesions, right? These cystic lesions in the liver with peripheral calcification. They can develop cystic lesions within the lungs also, although they don't calcify within the lungs. And when the cyst ruptures, you can get that peculiar appearance there within the lungs. I won't go through the disgusting life cycle. You can study that on your own. Okay, but the cyst is made of multiple layers. There's the pericyst, which is the fibrotic capsule of host tissue, the exocyst or the ectocyst here, the outer laminated layer, and then the endocyst, the inner layer where the daughter cysts hang from. And when the cyst ruptures, air can get in between the layers, and then that's what makes the cyst collapse into the dependent portion. There's also some fluid in there, and that's what gives you this very peculiar appearance of a ruptured echinococcal cyst within the lungs. So here's the cubitus view showing you the air fluid level and the different layers of the cyst wall. So that air crescent sign, this can also give you an air crescent sign when it ruptures as the air gets in there between the layers of the wall. And here's a floating around in the dependent portion, that's called the water lily sign or camelot sign. So it's a sign of a ruptured hydatid cyst, that peculiar appearance of stuff floating around in the dependent portion of the cyst. Before it ruptures, it's a fluid attenuation lesion. So it's just a big round mass before it ruptures. It's after it ruptures that you get the air between the layers of the cyst wall. Okay. And so here it is before it ruptures. After it ruptures, now you see the air in there and it crumples down and floats around in the dependent portion. And we don't get calcification. Unlike the lesions in the liver, which commonly calcify, we do not get calcification within the lungs. What is this called? Well, it might be a bulla, lung cyst, but you have an air-containing lesion that is round and has a very thin wall. Pneumatocele, right? It's a particular term for that. So pneumatocele, what's the difference between a pneumatocele and a bulla?
Size.
No,
I thought it was size.
no, not necessarily, no.
Bulla is like associated with the pleura.
No. What's different about the location? They're both in the parenchyma. Technically, a pneumatocele is an air collection in the interstitium, right? Whereas a bulla or a cavity, that's occurred in the lung parenchyma. Cavity, lung tissue is destroyed. Bulla also, lung tissue is destroyed. But a pneumatocele technically occurs because air dissects into the interstitium of the lung. And so that gives you pneumatocele. And that's why pneumatoceles can resolve, because over time these things can resolve. So that technically is what a pneumatocele is. So here we have this particular appearance. What underlying disease would this patient have?
ARDS.
Hmm?
ARDS.
Well, you suggest ARDS because you have what? You have ground glass consolidations and you have nematoceles. In this hospital, though, there might be one thing I would suggest before ARDS in a patient with nematoceles and ground glass opacity. What? Pneumocystis pneumonia, yeah. So it'd be important to know if the patient's HIV positive. But pneumocystis infection is notorious for giving you nematoceles. Okay, so pneumocystis is an infection that can be associated with nematoceles. What other infection is associated with nematocele formation? Staph, especially in children. So staph can also give you nematoceles in children. So nematoceles, thin-walled air cyst, so it represents dissection of air into the interstitium. It can be associated with barotrauma, can be associated with regular trauma. Pulmonary lacerations can go on to form nematoceles. Hydrocarbon ingestion is a rare cause of nematoceles. So these are different things: infection, staph, pneumocystis, other necrotizing bacterial pneumonias. Pneumocystis pneumonia we talked about. Hydrocarbon ingestion, that's a rare cause of nematocele formation. You might see that in kids who ingest hydrocarbon, gets in the lungs. So 2 images from this CT scan on this patient. So what do you think the history was for this patient? Trauma, yeah, because there is a big pneumothorax. So what's happening in the lungs? Well, what do we have in the lungs?
Layer consolidation.
What does the consolidation represent?
Blood.
Blood. So is this normal? So what are these? Those are lacerations, right? So in a trauma patient who has these irregular air collections within the lungs, those are pulmonary lacerations. Those are tears in the lung. They can fill with air and blood, right? So these can also go on to form nematoceles. So the consolidations then in this trauma patient represents pulmonary hemorrhage. This is bleeding within the lungs in a patient with trauma. So trauma is another cause of pneumatocele formation. Can you see the finding in this X-ray?
Round opacity, the left one goes.
Yeah, anything special about it?
It is cystic.
Yeah, surprise, it's cavitary, right? It's got that lucency there, okay? So let's show you some CT images. See it? There it is. Anything else? Right, is that the only lesion in the lung? Yeah. Well, by the way, first, is this the only lesion in the lung? Yes or no?
No, there's one.
No, there's one on the other side, okay? And you said there was something in the, just one thing?
No, there's something to go into.
Yeah, there's more than one. How do we put this together? So you have lesions in the airway with thin-walled cystic lesions in the lung. Well, one thought might be, remember we said what kind of tumor gives you cavitary metastases? Squamous cell. So could these be squamous cell metastases? Yes.
I was thinking about they don't look aggressive enough. Like
They don't have to be, right? I mean, you know, they get all kinds of varieties with that. So it is a thought, but the appearance though of classic lesion, this is a classic appearance of this particular disease. Airway lesions associated with thin-walled cystic lesions in the lung. What is this? These are papillomas, right? So this is called, yeah, right? This is papillomatosis, tracheobronchial laryngotracheal papillomatosis. They develop these papillomas within the airways that can spread into the lung and give you those thin-walled cystic lesions. Right? So here's virtual bronchoscopy showing you all these lesions here along the airway walls. That's just mucus, but the rest of these are lesions along the airway walls. In this patient with tracheobronchial papillomatosis. In the same patient, the follow-up study shows this. What follow-up study am I showing you? Yeah, it's a PET scan. What does it show?
transformed
To
squamous cell.
squamous cell cancer, right? So that's the complication of this, is transformation to squamous cell cancer. So this is respiratory papillomatosis. It's caused by HPV infection. We see it in patients with AIDS. So the virus there goes along the airways, causes the papillomas, gets into the lungs, and causes those cystic lesions in the lungs, and the complication is transformation of squamous cell cancer. It can also occur in children, exposure to virus during passage through infected birth canal. So children can also develop respiratory, or babies, infants, respiratory papillomatosis. In adults, though, it's associated with HIV. And remember, transformation to squamous cell cancer. All right. So that is our discussion of multiple lung nodules and cavitary lesions. Do we have any questions? No? Okay, see you guys next time.